No. So I request Dr. Mohan Rajan sir for the discussion on RHEXIS tips and tricks.
Thank you very much, sir. Let me thank the AOS for this wonderful opportunity, and it's always a pleasure to come back to Vizag, and I have a lot of very good memories about Vizag as well. Yeah, can you take it. So I'm going to talk to you in the next 7 minutes about this RHEXIS tips and tricks, and these are my financial interests. So as you know, capsular RHEXIS is a continuous curvilinear capsulotomy, and you know the pearls are, you need to visualize, make sure that you have a good red glow. For example, you can see this is the needle RHEXIS I'm doing. So the most important thing is the needle RHEXIS. Either you can use a needle or you can use a Utrecht forceps. The Utrecht forceps can be regular Utrecht or a micro RHEXIS or whatever you are comfortable with. Only thing is, make sure that your anterior chamber is always deep. A shallow chamber is the worst enemy for a capsular RHEXIS to go out. So again, very important, you can see this is called the, I am just pinching the RHEXIS. So this is called the pincho RHEXIS, I call it pincho RHEXIS. In immature cataracts, you can do that. So you can see here, I am pinching the RHEXIS. Again, I am making sure that the anterior chamber is deep. And if you are using a Utrecht forceps, every 3 clock hours, you need to shift your grasp. Okay, shift your grasp. You don't pull the thing, always go to the base of the, as you can see here, every 3 clock hours, I am going to the base of the capsular RHEXIS, and then I am pulling it from outside in. Again, very important. This is again another patient with the pincho RHEXIS. Since we have very little time, we will go through it very fast. So again, RHEXIS in PPC is very important. Why? Because you don't want to have a small RHEXIS, you don't want to have a very big RHEXIS. Why? Because if you want, if there is a pre-existing dehiscence of the PC, then you need to capture the lens, multi-piece lens in the capsular RHEXIS margin. For that, if you have a very large RHEXIS like 6 millimeter, you will not be able to capture it. So again, RHEXIS and PPC again very important. Small pupil can go to do the RHEXIS underneath the pupil. How do you do underneath the pupil? So underneath the pupil you do, I use usually Utrecht forceps, very difficult to do with the needle. Of course, you can do that as well. You can see here I am following the margin of the RHEXIS underneath. So actually the RHEXIS size is bigger than the pupil size. So the pupil even comes down a little because these patients are all on Urimax and they may come down a little. Then it doesn't matter for you because you know exactly where your RHEXIS is, and you can go ahead and do the vertical chop. Again, another patient, you can see here how I am trying to do the RHEXIS, making the RHEXIS bigger than the pupil. Very, very important for all of us, especially in the mid-dilated pupil. If it's small pupil, then you can go for iris expansion devices. Mid-dilated pupil, you can do that as well. So escaping RHEXIS, you can see this is a mature cataract. When it's escaping, here, stop. Here you just stop here because come out of it and then put in a viscoelastic. Preferably I use a viscoat. I don't have any financial interest. Then use a micro RHEXIS forceps and try to pull it towards the center. Again, very, very important for you to understand this ball game. Again, another patient with the escaping RHEXIS in the periphery, and I'm trying to, so whenever you have a escaping RHEXIS, switch over from the needle to the Utrecht. Why? Because you have Utrecht, you have better control and you will be able to get the RHEXIS inside very nicely. Again, another patient, you can see here, this is a patient with the, this is a white cataract. The white cataract is always a challenge. The intumescent, the mature white cataracts, hypermature. The most common is the intraventricular pressure is very high in the type 1 white cataracts. You can see this is the patient. You can see that the Argentina flag sign has occurred. As soon as they touch it, it's going to the periphery. Okay? And this is one of the patients, you can see here what I'm doing is, this is another patient, you can see the type 1 intumescent cataracts are very dangerous because despite the fact I was using a viscoat for this patient, I was going, you can see that as soon as they touch it, it's going to the periphery. The problem is the RHEXIS tear which is on the opposite side can wrap around the equator and you can lose the nucleus. And this patient was a union minister, and you know these politicians commit a lot of sin and they come to you, and the physician was watching through the side tube, and he wanted a multifocal lens. So what I did was, so I just tried to, fortunately for me the cataract is not a very hard cataract. If it was a brown cataract, probably would have converted. I could have just gone ahead with the thing, with the phaco as well. But you can see here, I'm trying to convert one part of the RHEXIS into a semicircular RHEXIS, the other part. I don't want any tags there. So again, I'm making sure that I'm converting that one part of the RHEXIS, and then I went ahead with the phaco modification. The preferred technique is the direct chop. I'm using my chopper, the Mohan Rajan chopper, which is made by AIOCMTC2. I don't have any financial interest. Again, just bring that nucleus a little up, because I don't want that any stress on the bag. So I don't mind losing some endothelial cells because I put some viscode. Fortunately for me, as I told you, this patient had a grade 2 cataract and I was able to manage, but not a multifocal lens in this case. I put a unifocal lens into the bag. Again, this is a problem in the type 1 cataracts. See, the problem is there is a pressure underneath the anterior capsule. The nucleus is bulky. There is a pressure in front of the posterior capsule, and there is a positive vitreous pressure also. So if you put a needle, for example here, this is a 30 gauge needle, you can decompress the anterior segment. You can decompress the anterior segment, and you can, that is the first component you can decompress. But you are not debulking the nucleus. You are not taking care of the pressure in front of the posterior capsule, which is actually pushing the nucleus in these types of cataracts. So as see, you can get away in about 50 to 60% of the cases without any, or if you have access to zeptorexis. Only thing is, it's a very, it's an invasive technique. If you have a shallow chamber like a phacomorphic glaucoma, or which I have access to femtocatalyst laser, this is a 100% foolproof method. This again, a patient you can see here. What you can do is in these type of mature cataracts, you can do a small RHEXIS there, but make sure that you use a phaco probe and trench it. Because the nucleus is also bulky, you need to make a trench and then try to extend that and make it a little bigger. Obviously, you cannot, because this is a very hard cataract, you cannot do this with this small RHEXIS. So I'm trying to, when you extend the RHEXIS, make sure that you use a vitreous scissors and cut it obliquely, not cut it like this horizontally, because you can go to the periphery. Again, very important for you to understand. If you're going to extend the RHEXIS, make it inside out. If you're going to make the primary RHEXIS, make it outside in. This is again a puncture RHEXIS which I have devised has become very popular now. I'm using a phaco needle, beveled down. I'm using a 15 degree and just punching. See, as you punch, you punch not only the anterior capsule, but also debulk the nucleus as well. So you're able to, you can just put any viscoelastic there and you can go ahead. In this case, the RHEXIS will not extend 100% and produce Argentina flag sign. You can again see here, I'm putting blue Rex, and then I'm using just simple HPMC. No viscode, no hyalon, because I don't want anything to occlude the tip and the anterior capsule. I'm going at and going all the way down in the stitch, just like you go all the way down on the accelerator in the car. So it's very important. And this puncture RHEXIS not only takes care of the front component, but also of the posterior component as well. I'll take another 30 seconds more, sir. Just to show you this phaco RHEXIS also you can do. With the phaco, it requires a little bit of learning curve. Again, the little rescue technique is something which you can see here. When it goes to the periphery, try to pull the RHEXIS in the same direction as you are going. This is called the Brian little rescue technique. As you can see here, I'm trying to do that, and you can see that you can do this thing. Again, hydro rupture, very important. You can see here, I'm trying to do the hydro. See, notice what is happening. I'm not decompressing the nucleus, and you see notice what is happening. There is a rupture of the anterior capsule. This 100% will extend across the equator and go, you can lose the nucleus into this thing. RHEXIS started doing IA, RHEXIS extended, and all these are very, very important for all of us. So thank you very much for the wonderful opportunity, sir, and the patient attention. If you have any questions, I would be willing to answer. Thank you.
Sir, excellent presentation. Sir, sir, I have one or two points regarding this. Generally, we should replace the aqueous with the viscoelastic before proceeding for the capsular RHEXIS.
Yes.
That should be first for the post-residual tip.
Yes, sir. Yes, sir.
So the cannula should go to the opposite meridian and replace the aqueous with the visco.
Yeah, correct.
Number second is that we should do under high magnification.
Yes.
RHEXIS.
Yes, sir.
If we do in under low magnification, you may have some difficulties. So number second, I want to know what, suppose we do a RHEXIS by capsulotomy, then people shift to the forceps. There are some difficulties. once they enter their shallow chamber. Can you tell some tips how to learn the RHEXIS by the forceps?
No, very easy, sir. Only thing with the needle you can start and create what is called a guide flap. So the guide flap, either you can go to the right or you can go to the left, depending on whatever you are comfortable with, and create a guide flap. And then once you create a guide flap, then use a good viscoelastic to deepen the chamber, and use the RHEXIS forceps. Only thing is you catch the base of the RHEXIS and not the tip. Catch the base of RHEXIS and go around in a centripetal fashion, so that you are always pulling towards the center. And whenever every 3 clockwise, as I told you, I demonstrated very nicely in that, you need to replace the gel and then go in and regrasp the flap at the base of it. Every 3 clockwise, you regrasped.
Forceps should not press on the wound lip.
Yes, absolutely.
That's important.
Yeah, you mentioned, yes, it's a very good point, because when you go in, normally the tendency for beginners is to keep the, press the forceps on the posterior lip. If you press the forceps on the posterior lip, what will happen is, all the viscoelastic will come out, and the AC will shallow, and the RHEXIS will go to the periphery. So, you don't want that to happen. So, always keep the forceps on the anterior lip. Keep it on the anterior lip, that is towards the cornea, you keep it, and press it against the cornea, and then you'll be able to do it. Or you can go through the side port with a micro RHEXIS forceps also.
Sir, regarding
to avoid all this, you start with the side port as a capsulotomy. You always use a micro forceps. Forget about uterata forceps. You will like it, and there is no chance of chamber collapsing. Do with micro forceps.
Yes, sir.
Sir, I have a question.
Yeah.
When you're teaching your fellows for the first time, most I have seen you, you're doing your RHEXIS anti-clockwise. So when you're teaching a fellow, because they do not know which direction is right.
Either is
Clockwise or
correct.
anti-clockwise.
Either one is
Yeah, that is fine.
But
What?
I mean, what is the ideal way to teach them? How will they know?
You ask him to try once right side, once left side. Which is convenient for him, leave it.
What I always told my fellows is, I asked him to draw a circle on a paper. So if he draws his anti-clockwise, that is the way he has to do. That is the most comfortable direction. If he draws it in the anti-clockwise, I mean the clockwise, then that is the right direction for him to learn.
No, it doesn't matter, sir. Anyway, because as right-handed surgeons know what because it's going anti-clockwise is a little easier than the clockwise. Doesn't matter. Many surgeons do that clockwise as well. It's all
Majority do anti-clockwise.
Yeah, majority do anti-clockwise.
majority
Yes,
do.
yes.
Because the advantage of anti-clockwise is that the guide flap you can create much better, because you are a right-handed surgeon mostly. Unless you are a left-handed surgeon, you create that make that initial this thing on the capsule, and if you go towards the right and then flap it. Okay, if you go to the left also you can do that, but the right is definitely more comfortable, because you are a right-handed surgeon, no?
True, sir.
Sir, whenever there is a liquefaction within the lens, we will find it difficult to use the needle. Maybe at that time, either microforceps or the RHEXIS forceps may be the first choice itself.
No, you have to evacuate the liquid.
Yeah.
Evacuate the liquid thoroughly, then you can enjoy it, because the tension is not there. Intralenticular pressure is gone once you evacuate it. It behaves as that of a normal case.
Yes.
Yeah,
Yes.
that's what I mentioned. No, the puncture RHEXIS, why it works? Because you are using a bigger needle, bigger bore, for example, the phaco. So it is able to decompress both the front as well as the back compartment, and because you are giving phaco also, it debulks the nucleus and pushes it back. So all within a millisecond it occurs, because you don't give the time for that nucleus to come forward and open the RHEXIS. That is why the puncture RHEXIS, it's a very, just try it, sir, it's very easy.
Sir, one more point is regarding the hypermature, mature cataracts, the needle RHEXIS becomes a bit difficult at times, even the fibrosed capsule.
Yes, sir, yes, sir.
So we should use.
I had some videos, but because of lack of time.
We should use the forceps.
Absolutely, sir.
In
Any
those
difficult
things.
situation, use the forceps.
Can you, sir, tell us about the shear and tear technique by using forceps? Shear and tear technique.
Yes, sir. The forceps, the advantage of the forceps is that even with the fibrotic capsule, you can go beyond that fibrotic area and come in that clear area, and you can go to the periphery also. The problem with the needle is that you cannot go too much to the periphery, and because you don't thing. Whereas in a RHEXIS, it's not only shearing, but it's also tears with the Uttrata. So both the techniques, both the things are, the features are there with the Uttrata forceps. That is the advantage, and you have better control.
Sir, I want to say that shearing you do a tangential this.
Yes, sir.
And tear while you feel it is extend, you can tear it centripetally to
Yes.
bring it back.
Yes, sir. Yes, sir.
Thank you very much, sir.
Thank you very
Excellent
much. Thank you very much.
presentation.
Thank you very much,
Sir,
sir.
next I will call upon Dr. Akshay Goyal. He will speak on nucleus
Yeah, yeah.
management in soft cataract.
Quick, yeah.
When it is a Morgagni cataract and we are doing SSCS, what do you advise at the capsulotomy part?
Yeah, it's very difficult because when you have a Morgagni cataract, always you stain, that is one thing, and then you make a small
envelope technique.
envelope technique and try to make, because you don't have the support underneath. Because the nucleus is small, you don't have the support underneath. So again, I would prefer to use a forceps for this. I use a good, something like a shaft shell technique, which has been described by Steve Varshinov, both viscoat as well as hyalon. You put it so that you inflate the anterior chamber very nicely. You also protect the endothelium and keep the anterior chamber deep. And you can try that as well.
Like what you said is should be done after removing the fluid, sir. What I generally do is I give a small nick with my 26 gauge needle in the center. I
Then use
aspirate whatever fluid
saline.
is coming out. Then make the capsule flat with the visco and then start doing the.
Yeah, yeah.
Fine,
The
fine.
saline has
That's
to come
fine.
out. Yeah.
Using the
Yeah, I had some videos because of lack of time I couldn't show.